welcome back to the Full Code Podcast. Really need a different name for this because it's not the podcast. It's a case study series. So if you have any name suggestions, then send it my way. Had a little bit of fun doing the Full Code Medical Simulation. Again, no relation, no sponsorship, no money changing hands, just a great product that I'm reviewing and allowing everyone to get kind of a feel for if you're interested in it. And honestly, it's not for the quality of the product. It's not breaking the bank. There are even options where you can pay a little bit more and get CME credit, blah, blah, blah. So like I said, no endorsement, just a good product that I really enjoy using. And honestly, I had a lot of fun playing. So I figured we'd key up another one of those today. I know the last one we did was an alcoholic withdrawal with new fevers. Looks like a CLABSI kind of situation. But let's jump into the next one. All right. So for this one, we have, this is another quote unquote floor case. This is a patient admitted to med-surg floor for cellulitis, was on Q4-hour vitals. Nurse just found him on the floor. Great. Placed a C-collar and moved him back to bed. Rapid response team nurse, 71-year-old male admitted 2 days ago for cellulitis, found minimally responsive after an unwitnessed fall, trauma to head, RRT at bedside, cervical collar, placed one peripheral IV in place. So this is already lining up to be a bummer. And honestly, there's a couple problems with it straight away. One of them is, and this is maybe a little bit subjective, but where it says place a C-collar and moved him back to the bed. Typically, if you have a trauma, especially inpatient, let me rephrase this. If you have a trauma for an inpatient, someone who's already there, you find them on the ground and they're minimally responsive, you do not move them alone. Like, you don't move them really at all. You need to have somebody assess them before you're jostling things around, just in case they have an unstable fracture, what have you. So, let's see. Oh man, we got to click begin, but I have a feeling this is going to deteriorate rapidly. So let's go ahead and start. We got this gentleman not hooked up. I won't run through the layout again. If you're curious of how the basics of how this work, you can go check out the previous video. So let's open up the patient tab. We have 71-year-old male admitted to the hospital 2 days ago with cellulitis, now with decreased responsiveness after an apparent fall. Patient found on routine assessment to be minimally responsive next to his hospital bed with trauma to the left side of the head. Fall was unwitnessed. Patient is unable to provide any further history. So this is already keying up to be pretty bad. Progress note, unknown, beautiful. Past medical history, cellulitis, atrial fibrillation, diabetes, hypertension. So you can tell already that we got bad news, atrial fibrillation. So, and it's chronic. If you have chronic atrial fibrillation, what are you very likely on? Chronic anticoagulation. Let's see. Cefazolin, current medication, cefazolin or sulfasalazine. Oh, I think it's trying to cue me in. Oh, something bad's happening. I didn't see what the message said. Okay, let's get him on the monitor. That's bad. Bradycardia, looks like we have oxygen saturation 90 to 100%, respiratory rate 18, BP 159 over 75. So we're coming into this assuming that given his minimal responsiveness, he has a very high likelihood of having some sort of neurological issue. So he's on the monitor. You could put him on like a defib. I don't know how that will trigger the system here. I do want, because you'd consider this a trauma, so you'd want to make sure that you have good large bore access in case you need to do some resuscitation. So review of system, unconscious and able to ask. So that's pretty bad. Responds to pain only, lethargic appearing. So let's go ahead and intubate him. He doesn't have an appreciable exam. He's not protecting his airway. We'll go ahead and get him intubated. Now, I think for this, we have to call for an intubation. Okay, now, intubation drugs. I think those are boluses for the intubation itself, but Okay. There's like so many things you need to do at one time. So honestly, the first thing we'll do, because this is a trauma and he lost his airway, I'm going to actually go ahead and send him for a CT scan if I can figure out where that is. Investigations, imaging, CT of the head and C spine as well. So let's start there. That's not good. That's not good at all. So we'll start with the C spine. So this is a normal C spine here. Yeah, nothing terribly remarkable here. If we weren't in an emergency, we want to make sure you go through this systematically, check each of the vertebral levels, make sure the disc height is appropriate. This person has some like osteophytes in here. Always make sure you look up high, look for C1 fractures. Those can be really bad. But this one's normal. We're not going to waste time on it because the other one is horrific. So this, it doesn't give you I'll just let you zoom in. It doesn't give you a interpretation, but I can tell you straight away, this is an epidural hematoma. Looks like you have midline shift, some mass effect. Okay, so this is a bummer. Now, okay. So we need to do a couple things. Current medications, warfarin, 5 milligrams. So he does take warfarin. Oh my gosh, bradycardia hypotension, or not hypertension. But we have a very wide pulse pressure. All these things look like they're potentially indicative of rising ICP. So let's do a couple temporizing measures. First, one is going to be mannitol bolus. Let's get that in. Let's see. We probably should start him on some propofol. Propofol can help with your ICP. You can consider giving him a fentanyl bolus. His blood pressure can handle it. That way you have adequate sedation to help with that. You have analgesia to help with that. And then we have mannitol to hopefully relieve some pressure. But ultimately, the definitive treatment is going to be surgical evacuation. So let's call neurosurgery. Neurosurgery says the neurosurgeon will meet the patient in the operating room. Make sure you have sent pre-op labs. Good job. Okay, thanks, buddy. So we did have some reduction in systolic blood pressure. I was still very bradycardic. I don't know if it'll let me actually do an exam on this cat just for the sake of completeness. So left pupil is 5 millimeters compared to the right, which is 3. That's a bummer. Neck is fine. Irregular rhythm, so consistent with atrial fibrillation that we know already there. Cleared auscultation bilaterally. Lungs are good. Abdomen soft, non-distended, normal active bowel sounds. Great. Normal. It's probably not going to be normal, I guess, other than the brain stuff. Intubated and paralyzed. The left pupil is fixed and dilated. So fixed and dilated is bad. Bad. So he is on the monitor. He's already intratracheally intubated. He doesn't need any adjustment and oxygenation. He doesn't need any fluids. The one thing that we would do in real life is, especially if he's on the ventilator, is crank that respiratory rate up. Bedside tests. So pre-op stuff. Oh, blood sugar. Always get a blood sugar. Chemistry. We'll do the basic pre-op stuff. Calcium ionized coagulation panel. CBC. No. Don't need that. And is type across an option? Yeah, type and screen. Oh, we need to do some reversal too because he is on warfarin. So what is the preferred method? Can you get that out of my search bar? Thank you. PCC, prothrombin complex concentrate, and vitamin K. I'll talk more about this once we get out of the acute phase. So, okay, we gave both of those meds. We'll just check our investigations really quickly. Nothing. No. Well, you can see INR is elevated, which we just tried to correct. Calcium, chemistry. Okay, so let's just do a quick recap. He is endotracheally intubated. Ideally, and I don't have this option, he would need to have his head up, at least above 30 degrees. Keep his neck midline, adequate sedation. Make sure you have some analgesia on board, especially given this is a trauma. We want to reverse any underlying coagulopathy. We can administer mannitol, which we did, as a osmotic diuretic to hopefully reduce some of the ICP. And we need to throw in a differential, which is easy, epidural hematoma. And then we need to hand him off. Oh gosh, did we do everything right? I feel like I'm gonna get penalized. Transfer to the operating room for a diagnosis of epidural hematoma. Prep for operating room diagnosis of epidural hematoma. Are you sure? Yes. Oh yeah. Ooh, what did I miss in stabilizations? Okay, so this will be a good breakdown. I love simulations like these because one of the things that it does really well is it, especially when something like this happens, there are a lot of things that need to happen all at once, and often you only have two hands, and you might be the only one there facilitating. Now, if you're in a larger, better staffed hospital, whatever, you might have more hands to help assist you. Hopefully that's the case. But I have been in situations where there's an emergency popping off. It's like me and one other person. So you got to be able to think quickly and prioritize. Now, luckily this is a game. So we have at least a little bit of time, even though he tried to crash out on us briefly. So let's go through this. Review of systems obviously is negligible because we can't do that with him. He can't respond. We got 100% on our examinations, which duh. Let's go to our stabilization, see what we missed. So attached monitors, critical call for intubations, critical. Let's see what else. I said that. Vascular access or an interosseous line. I probably should have looked harder for that, but as we've mentioned, most of you already know, if you have an active trauma or somebody, there are a number of reasons. Active trauma, GI bleeding, massive hemorrhage of any kind. You want 2 large bore access points to be able to do some adequate resuscitation. And do not forget this, right? It's nice if you have a central line or a PICC line. Those things are cool, but you can get more flow out of a larger gauge peripheral IV than you can out of a PICC or a central line because of obviously the gauge. And there are a number of factors that go into it, which we could break down one day, but make sure you have 2 large lines. Is that all we missed? Yeah. Okay. Investigations. C-scan. Yes. Finger stick. I did a finger stick glucose. Maybe I didn't click the button. Chemistry. I did that. Okay. Maybe it's just telling me that those are recommended. Okay. Blood type and screen. I know I hit that button. That's whack. C-spine, head, finger stick, Chem 7, ionized calcium. Yeah, it's kind of irrelevant. And let's jump down to the interventions. I'll talk about some of these right away. Osmotic diuresis is critical. So it's important, but the most critical intervention in this case is surgical evacuation. Mannitol can help you for a little bit, but really you need to get them to an OR. Let's see, propofol infusion, which we did. Yes, fentanyl bolus, we did. PCC, we did. Vitamin K. Cool. What did I miss? Place orogastric tube. Okay. I get it. I mean, just essentially every patient that gets intubated has an orogastric tube for both gastric access, but also decompression if it's needed. TDAP. At some point, the TDAP should be updated for this patient since they have a potentially contaminated laceration. That is technically true. That is not the first priority. I don't even know why you would include that here. Be like, he's crashing. We need to make sure we get him that TDAP before he hits the OR. Okay, so why don't we talk about some of the components of this? Let's see. Hold on. Okay, that's better. So let's talk about some components. Let's talk about epidural hematomas themselves. So broadly speaking, there are several different kinds of bleeding in the cranium, right? Very broadly, you can just call them ICHs, right? There are more specific terms that can come out. Sometimes you'll hear bleed referred to as like intraparenchymal hemorrhage. You might hear that. Sometimes they're referred to, often by their kind of anatomical geographic location. We often lump epidural hematomas and subdural hematomas together because they are of a similar nature, even though they're fundamentally different. I would say that they're fundamentally different in their severity. So epidural hematomas, they often call it wake up and die, or like talk and die. Either wake up and die and or talk and die, because you often have an initial insult, trauma. You may have a concussive episode or even a brief loss of consciousness, and then they wake up and they're normal and talking to you, and then they have a sudden decline. That is due to the nature of the bleed. Now, let's keep it simple. Subdurals are slow and epidurals are fast. Epidural bleeds typically are arterial in nature. Subdurals are venous in origin. Now, what makes an epidural hematoma so bad? The same reason anything that causes a shift in the intracranial hemodynamics quickly, or anything that can do that quickly, can cause major damage. So one concept I'd introduce, or at least maybe by comparison, is when you have patients that have large brain tumors. So when we talk about like meningiomas, that's a great example. A meningioma is a slow growing tumor that comes off of the meninges, right? But it's not abnormal that when you find these things, they're pretty large. It's, in my experience, there's any number of presentations, but a very normal, common one that I've seen is somebody is just having dinner, and then all of a sudden, boom, they have a seizure, pass out, wake up, and you're like, oh my gosh, what happened? And then you go in and you're like, they get their CT scan and they have this, sizable meningioma. But it's able to lay dormant for a while because of how slow it grows, and it very slowly displaces brain tissue, which is good. It's good in the sense that when you pull it out, even though it's never guaranteed, you might have some functional recovery of that tissue because it hasn't been completely obliterated. Now, you can apply that similar concept to a subdural hematoma. Since it's slow, it builds up gradually. This is why they're so insidious, is that you can have somebody, again, another common presentation for a subdural hematoma is, Mimar Peepaw is at the restaurant. They fall down on the concrete outside. They're on chronic anticoagulation, but they get up, hey, I'm totally fine. And then some amount of time later, they come in and they're like, oh yeah, I'm dizzy, I have a headache or whatever. And they tell you this, and you've had this slowly building blood pocket that's, below the dura. And that starts to, that will eventually get large enough that, it starts to have a symptomatic manifestation. And then you have acute on chronic where someone either, for a number of reasons, one of them might be that they require chronic anticoagulation, will have recurrence of subdural hematomas and become symptomatic eventually. But the epidural hematoma, like I said, is fast. It displaces brain tissue very quickly and essentially can destroy it. The goal is to get in there, get the blood out, and stop the bleeding. So one thing I'll qualify for some of the things that we'll go over is that neuroscience, neurosurgical guidelines come in different flavors. For example, there are different guidelines or treatment algorithms that might come from, say, the Neurocritical Care Society through ENLS, which if you've never heard of, is really cool, very informative. You should absolutely check it out. There are recommendations that come from, what is it called? I think it's the Seattle International Severe TBI Consensus, SIBICC algorithm, among others. So when you talk about what is the right thing to do, not everybody's going to be pulling from the same pool, and not all the pools aren't always the same. But the general principles will still be true. And epidural hematoma, generally, this is kind of silly to say, but an epidural hematoma should be evacuated if the size of it is greater than 30 centimeters cubed. It should be surgically evacuated regardless of the GCS score. Now, that being said, in my experience, and this maybe isn't always true, but in my experience, every time someone has an epidural hematoma, they're going to the OR because they need to stop that bleeding before it gets any worse, because the risk is really high. Comatose patients, so, a lot of us think GCS less than 8. Sometimes they'll cite GCS less than 9. If they have either less than 8 or less than 9 with quote unquote like unequal pupils or anisocoria, which we've talked about before, they also need to undergo emergent evacuation. Now, what is the clinical significance of, like, say, unilateral changes in a pupil? Now, we won't we could talk about visual pathways all day long, but, let's break it down to its most simple constituent parts. Is you have what we could call a space occupying lesion. In this case, it's a hematoma that's invading a space deep enough to the point where the pathway for control of the eye has become compromised. And that's a bad sign. Like, that's a really, really bad sign. And ultimately, the moral of the story is, if you see this on a patient, they have to be immediately evaluated. And the vast majority of them, even ones with really high GCS scores, are still going to have to go to the OR for evacuation. So that's just general understanding of epidural hematoma. Let's jump over to the mannitol component of this. So this shifts us into some of our thinking in regards to how do we manage elevated ICP. Now, sometimes that can be a question of what is the nature of the elevation. We might know that, what is going on here and how we might treat that. For example, you might have a fresh stroke patient who is within their swelling window, and you're like, you see that they're becoming more symptomatic of their stroke, in which case they might start some continuous infusion of hypertonic fluid to help, pull some of that fluid out of the space. Mannitol is another agent that you can use. Generally, I think it's 0.25 to 1 gram per kilogram IV. And this, again, we've talked about it before. This is temporizing. This is not curative. Mannitol is not going to cure you. Hypertonic's not going to cure you. The other thing is that in this setting, mannitol versus hypertonic, as far as I'm aware, unless something has changed, one is not superior to the other. I think when it came to hypertonic bolusing, that does get a little tricky because there's many gradients of hypertonics fluid. People are very often familiar with 3% normal saline. I believe there's 5, there's 7, and there's some others. And then there's, was it 23.4? It's been a long time. There's the sodium bomb. We have those. And, one other thing to consider is there's a lot of recent conversation around using sodium bicarb as in settings of increased ICP because it's so hypertonic. It's such a hypertonic solution. So when, I know for us, because if I was asking myself, when do you use one and the other? We'll just apply it to the situation for the sake of keeping it simple. When would we apply one versus the other? When we call the neurologist and ask them what they think. But ultimately, you need to get this patient to the OR. That's really the end point here. Anything that I can do is going to just be something that temporarily buys us time and hopefully doesn't allow this patient to get any worse. What was the other constituent components in this? So we talked about epidural hematoma. We talked about hypertonic administration, or in this case, osmotic diuresis. Reversal. So it says in this situation that this patient is on warfarin. That is not an uncommon situation, especially in the hospital. The reversal agents for this, now it's tough because I don't know if people, obviously there are practice pattern changes everywhere. Whenever you're at it, whatever institution you're at, especially as a provider, you want to ask, like, what are the capabilities that I have? Do I have access to this drug, that drug, or this, blood component, that blood component? Which, for the most part, you're going to have access to a standard fare of things. In this case, we're going to use something that is a little less typical in, let's say, medical ICU world, but it's 4-factor PCC. Warfarin reversal is honestly not a very complicated thing. You can use 4-factor PCC, and then on top of that, you're going to use vitamin K. Now, 4-factor PCC has purified preformed functional clotting factors. So, and that's 2, 7, 9, 10, and then protein C and S. I think that's it. That are obtained from pooled human plasma. So you have those clotting factors in there already, whole bundle of them. And then there's vitamin K, which is the other name. I don't know that I've ever actually looked up how to actually pronounce the other name of it, but we're just going to call it vitamin K. Vitamin K is the specific antidote. It directly competes with the warfarin at the binding site. So it basically just overwhelms warfarin's competitive inhibition and restores your vitamin K cycle, basically. I know that everybody here remembers the clotting cascade and loves talking about it so much. So, not too hard overall, kind of a little bit tricky just because it's you have to think very quickly on your feet, and it'd be very easy to get overwhelmed in a situation like this. Let's circle back to some like non-farm stuff. When we talk about ICP elevations, there are a number of strategies, I'll call them strategies, that you can use to hopefully mitigate some of it. Again, as a temporizing measure. It's all good and fun, right? When you have not fun, but it's all a good and, let's say, fine when you have something like an EVD. So that can be adjusted. We can allow for some offloading, reduce some pressure. But in this case, that's not going to save you. You need to get control of this bleed. So we had mentioned before, making sure that you're sitting up and have your neck midline the patient, not yours. So that we can maximize venous drainage. What else? You want to introduce any form of sedation, especially if the patient is agitated, which is not at all uncommon after a head injury. Now, this patient became unconscious, so whatever. that makes it a little bit easier, but you still would want to proactively give we did propofol and fentanyl in this, and those are both good options to help with that. Another thing that we talked about was hyperventilation. I think I had mentioned that briefly. Hyperventilation is going to help you blow off more CO2, and in turn, it's going to cause some degree of vasoconstriction, with the hope being that you can reduce blood flow to that area while you're essentially en route to the OR. But that is another strategy you can use. I don't know. I think that's about it of the just general non-invasive, non-pharmacologic measures that you can do. And then obviously hypertonic, reversal, definitive surgical management. And then post-operative care, honestly, is going to be really important. When you look at, I wish I could pull it back up, but obviously that image that they obtained was a real image at some point. You can see that based on that image, if you want to go back and look at it, that that epidural hematoma is very, very large, and it's very likely done a lot of damage. And given that the patient has underlying coagulopathy that's pharmacologically induced, hopefully after we give those antidotes, we can repeat our coags, especially postoperatively, make sure that it is maintaining being sub quote unquote therapeutic now. But the other thing that we need to consider is that while we might be reversing this for this immediate life-saving intervention, the cessation of anticoagulation in the setting of somebody with chronic AFib leads to an increased risk of ischemic stroke. So you always have to weigh that against the other. But if it's that or die from an epidural hematoma, we can maybe hold off on the warfarin for a minute. The other component is that, and you would generally want to ask this because people who are on warfarin are generally on some sort of managed care where they're having, especially if they do this chronically, where they have their INRs checked routinely. They may have a specific dosing schedule of, X dose on this day and X dose on this day for this duration. So I say all that to say, hey, when was the last time they had warfarin? The other component of it is that warfarin is kind of, I don't think this is controversial, but warfarin's kind of unpredictable sometimes. Now, we have a very standard approach. When I say we, I usually mean pharmacists or people who do this professionally. They have a pretty standard, we do this plus this and give this dose and monitor and make adjustments, yada, yada. But inevitably, and everyone who watches this will know that you've all seen patients where it's like you give them one dose of warfarin and suddenly they're INR 7 and you're like, what the heck? What the heck is this? Which honestly leads us to a good point. When you have these patients come in the ICU and they're not bleeding and their INR is 7 and you're like, and they take warfarin, which is not, I don't want to call it common, but it's not uncommon. Don't panic. Don't panic. If they're not bleeding, stop giving them warfarin. Watch them. Ideally, when you're watching them, your INR over time is going to fall, and hopefully you can, and again, this is context dependent because you are going to have patients that need to be on anticoagulation, but nobody needs an INR of 7. So you don't want to reverse it and introduce a new stroke, aggressively reverse it and introduce a stroke risk. If there's no bleeding risk, then you just want to monitor it. And then I think the guideline says no reversal if no bleeding until INR is over 10, which makes a lot of people panic. It's very common that you might see these patients come in or inherit them as an ICU provider, and they've had several rounds of FFP, fresh frozen plasma. They'll often do that to drop the INR, but I would point you again towards the guideline. If it's super therapeutic, but they're not bleeding and they don't have a risk of, if there's something else going on, or even if there's a part of your brain where you're like, I don't know, I'm having some hemoglobin drops, but I'm not seeing any externalization of this, i.e. blood leaving the body. Another common ICU problem, dropping hemoglobin that you can't see. You do need to make sure that you're doing a thorough physical exam and evaluating these patients. But in setting a bleed, vitamin K, 4-factor PCC, those are the main recommendations. I've seen people use FFP, but PCC is what's recommended. And then send them to OR and hope for the best, because you never know. And I think I'd mentioned postoperative care, neurological exams, preferably in an ICU with someone trained to do so. It's usually Q1 hour neuro exams. I know that is also a hotly debated topic in terms of, the damage that being kept up every hour on the hour for potentially days on end can have to the mind, versus the whole time is brain, which is very true. And early detection saves brain function, especially when you can mobilize a neurosurgical team very quickly. But postoperative care is going to be very important. INR stabilization, once cleared, making sure that you resume anticoagulation when cleared by neurosurgery. There are some arbitrary lines. There are some arbitrary timelines that are provided within guidelines. But in the words of one of my attendings, anticoagulation starts when neurosurgery is okay with it, which is a good general rule of thumb. I would never, even honestly prophylactic, DVT prophylaxis, we want, even though it's, like, I could be quoting this wrong, but I think it's correct. When you have certain kinds of bleeds that have been handled, whether that's a securement or what have you, generally prophylactic anticoagulation, not full-on anticoagulation, just like DVT prophylaxis, is usually okay, I think, in 48 hours. I'm going to fact check myself after this to make sure, but I think it's around 48 hours. And then for, I think, intracerebral hemorrhages, it can be like I've read 6, 7, 8, 9 days, whatever. We leave that up to our neurosurgical colleagues, and making sure that we're balancing risk of reward, making sure that we're following guidelines appropriately so that we can avoid secondary issues. And then obviously when you have a severe neurological injury, early physical therapy, early occupational therapy, and honestly referral to any form of neuro rehab if that is a resource that you have. So let's see, what are we doing on time? 30 minutes. So I wanted to try and keep these. It's hard to do an actual case analysis that is short, because you got to work through it, and then obviously we want to do some educating and talking through it. But I don't want to run this out for hours and hours. I know some of you want to do more complex ones, which I'm going to try and do these maybe a couple of times a week if I can, but because they're not really that hard to do, and they're fun. Enjoy them. But yeah, if you found this helpful, please give us a like, subscribe, comment, tell me which types of cases you'd like me to walk through or talk through. If you want me to do separate videos about some of these concepts, which I'm planning on doing, that way you can sit down and spend some time with the specific concepts instead of this, off the cuff, like just kind of pulling it out of thin air sometimes. But yeah, thanks for tuning in. Thanks for the support. Please follow, please share with your friends. Helps us out. Immediate future, next podcast will be in the next day or two, and we're going to do atrial fibrillation. We're going to talk about atrial fibrillation in the ICU. So be prepared for that, and we look forward to seeing you next time. Thanks.